Hi, I'm Dr. Patrick Felton. I'm here today at BrickBodies to present an educational in-service to the personal trainers who work here. More and more these days, people are turning to personal trainers for guidance with regards to their exercise and fitness activities. I feel it's very important to be able to enlighten the personal trainers about possible signs of problems that would require a podiatric evaluation in our office in order to make sure that these patients continue their motivated path to success with regards to their exercise and fitness activities. My name is Patrick Felton. I am a podiatrist. My specific sub-interest in podiatry is podiatric sports medicine surgery, and within that subspecialty, another subspecialty within that specialty is biomechanics and specifically computerized gait analysis. And the reason that this is so important to me is this is actually my background. I actually started out as a physical therapist and sports medicine rehab specialist, and I became very interested in really the intricacies of the foot and ankle, and that is actually why I chose to continue my career and further my career in the field of podiatric medicine. I've been practicing podiatry since '97. I'm not going to go through every single thing up here in this slide, but I can tell you I have a vast experience and background with podiatric medical conditions in all phases and all types of sports. Basically, I do love to work with runners, and obviously most sports involve some form of running or using our feet in some way, shape, or form. I did have a great opportunity when I was in Florida. I actually was one of the team physicians for the Florida Panthers of the NHL, which was a very rewarding experience. I've been up here in Baltimore since 2008. I originally hail from just up the road in Harrisburg, and after spending a lot of time down south between the states of Florida and Texas, I wanted to move back up to be closer to my extended family, but didn't want to deal with the potential weather that I dealt with growing up in Pennsylvania. Given the past two winters we've had here in Baltimore, that was a rather, I don't know what type of ironic joke Mother Nature was playing on me, but I am glad to be here in Baltimore. As far as my personal background with regards to sports, I had the experience of playing college football for 2 years with Millersville University up in Pennsylvania. After I decided to end my football career, my fraternity brothers somehow looped me into playing college lacrosse for the final 2 years of college. So been involved with many obviously high demand lower extremity sports as well as impact. And then when I went away to medical school, I had a few people loop me into playing ice hockey for 4 years there. So you name it, I did it. Cycling is probably my biggest passion. I've been licensed with USA Cycling since 1989. Most recently had the opportunity to win my division at a cyclocross race on Christmas Eve up in Pennsylvania, so that was very rewarding. And I am licensed as a triathlete, but the reason I'm licensed as a triathlete is I don't do tris, I do duathlon. So I'm the one who's stupid enough that once I've run one time and then ride the bike, I decide I want to get off the bike and run yet another leg. So, but you have to be licensed to do that. Recently became certified as a spinning instructor, and I actually will be auditioning this coming Sunday with BrickBodies to potentially become one of the indoor cycling instructors. I'm very active in this area. I live over in the little subdivision of Thornley, which is near the intersection of Seminary Road and Thornton Road. I am a corporate membership of BrickBodies, so I usually rotate between location here in Padonia, location over in Reisterstown, as well as the location just down the road from me over in Green Spring. So I've had an opportunity to be in a number of your clubs. I do coach with the Lutherville Timonium Rec Council, both in soccer and lacrosse, and right now I have the study guides at home, and I'm studying for the ACE Group exercise certification as well as the AFTA Sports Nutritionist certification. So again, with everyone in this room, between you and you all and myself, there is definitely a big common interest with regards to health and fitness. Again, I mentioned things, why do I do what I do? Well, to me, again, I felt that when I was in my years as a therapist, I was very interested in the mechanical intricacies of the foot and ankle. You know, you're talking about 28 bones, 40 joints, over 100 ligaments, and 33 muscles and tendons. When that piece of anatomy works correctly, life is great. when it's not working correctly, life isn't too fun for any of us. Obviously, that leads into number two, which obviously our entire livelihood does rely on our feet and ankles, whether you're active, whether you're not, whether you have an active job, a sedentary job, you still got to use every one of those feet every day, many footsteps, 7,500 to 15,000 steps. That's what the average human being takes in the course of one day. So when you're having problems and can't rely on them, again, life isn't that great. I'm a very energetic person. I like to surround myself with people who are energetic, and obviously sports and exercise, if you're not energetic, you're usually not involved with those activities. So I'm very much attracted to people who are energetic and like to be active. And the last thing is I'm very passionate about keeping those who are active basically active. You know, it very much disheartens me when I have a patient come into my office with a painful foot or ankle condition. They say, you know what? I can't go to the gym as much as I wanted to. I used to run 4 times a week. Now I can barely even walk on the treadmill, or I've had to give up running or do something else. And I can hear it in their voice and see it in their face that although they found alternative ways to stay active and keep their exercise regimen, I can see it in their face. They're not doing what they want to do. And that disheartens me, and at the same time motivates me to help them find the answers. Overall, when we look at health, and again, this is not anything that none of you already don't know, but obviously central to health, you have a number of facets in there. And you know, again, as I discuss things during my lecture, obviously I'm going to kind of stay away from lecturing to you about the things that you already know about. What I like to classify, and there'll be a slide about this later, called the extrinsic factors of physical health with regards to exercise. What I'm going to focus on more are the intrinsic factors, the things that I'm medically trained to look at to be able to assist all of you with your clients, so that way we have a symbiotic relationship between the path that you lay out for them with regards to those external factors and extrinsic factors, such as their training methods, their training intensity, their frequency of training, their ergonomics of when they're working out. You all are well trained in that. What I look at are the internal biomechanics of the patient, which leads to this. There is obviously an overlap between biomechanics and ergonomics. And again, ergonomics is how a person moves. When you have someone there in the gym and you have them using free weights and you're teaching them exactly how to stand and exactly how to move their arms, or you have them on the machine and say, okay, this is how tall you are, this is your reach, this is where we need to set this machine so that you're getting the best and safest workout. That's where ergonomics come in. Biomechanics is how a patient or person is physically built, or how their body actually moves. And again, some of that is genetically predetermined. But again, that's very important to understand that the form that you're trying to teach them is preceded by how that patient's body is built. And again, you can't have proper function of the body without proper form. And again, I mentioned that we have 2 components, which are extrinsic and intrinsic. And again, extrinsic, this is all the stuff that you are, as I am coming to learn as I'm studying for my ACE certification, you all are very much well educated about these facets. And obviously, as with the nutrition certification, I understand that some of you have also delved further just beyond just the personal training aspect into further more subspecialized things such as nutrition, as well as other areas. So they're the extrinsic components. And again, I'm not going to hammer that because you're all very well educated on that. The intrinsic components is obviously the biomechanics, how your body actually moves into relation to how it's built. And again, much of this is genetically predetermined. And again, if the biomechanics are faulty, you cannot overcome these faults by trying to utilize measures that address the extrinsic components of form. And I'll get a little bit more in depth with that later in the lecture. And to be honest with you, sometimes some of your clients who are actually struggling with certain things, it's not that they can't do it. Sometimes it's their body build or their body function and body form that doesn't allow them to do it. And again, with regards to the foot and ankle, I'll get into that in a little bit, how I can step in and help with that. As far as lower extremity biomechanics of the foot and ankle concern, obviously where the rubber hits the ground is the feet. So many of, if not 99.9% of what happens with regards to abnormal movement of the lower extremity comes from the foot. Sometimes the feet are compensating for abnormalities higher up in the lower extremity. However, I have come to find and appreciate in the 15 years I've been doing this that a lot of the abnormalities or problems in the knees or the hips or even the pelvic girdle and lower back are arising because the patient doesn't have a stable basis for support and function. And then, of course, trauma. And I put in parentheses here, Renee had forwarded to me some questions she had actually fielded from some of the trainers, and one of the trainers had brought up regards to someone who had a heel fracture and was a number of weeks or months out and was trying to advance their activity, and they had got some aggravated problems. I'm going to go into in a little while a little bit more why that potentially could be happening for that client. When we talk about abnormalities of biomechanics, essentially there's a foot classification system that we use. Basically, we have at one end of the spectrum overpronation. At the other end of the spectrum, we have oversupination, and nestled right in the middle is what is called a neutral position foot. And when we talk about classifying the foot, what we're actually talking about is while a patient is in motion, whether they are walking or running, we are talking about the split second in time when one foot is in contact with the ground, the other leg is swinging through the air, and the patient's center of gravity is centered directly over the foot. That is the contact point that we are looking at to classify the patient's foot function. So, and again, in overpronation, it's not because of muscle weakness. It's not that the patient's muscles that are attached to the foot in the arch area are weak. It's actually the laxity of the ligaments. The ligaments are the deepest soft tissue structures of the body. They're what connect bone to bone. They're made of collagen fibers. At the split second of all of our conception, the genetics are already there. Obviously, some of us have looser, more lax ligaments than others. I'm an example of that. I can be sitting up here on the desk and not putting any weight in my foot, and you'll look at the overall shape, curvature, march, and think, oh, that looks like a stable foot. However, when I stand down and take my center of gravity over that foot, you will see that the inside part of my arch, which is called the medial longitudinal arch, collapses down. If I stand facing away from you and you look at my heel looks like it's tilted outward away from out from underneath my ankle and my leg, and it will almost look like the front half of my foot as a result of the arch rolling down and the heel tilting out. It almost looks like the front half of my foot is pointing out away off center. So that, and of the biomechanical abnormalities, overpronation is the most common. Oversupination does happen, but we tend to see that less frequently. And then here's a picture again: loss of the medial longitudinal arch height, eversion of the heel, and it looks like the front half of the foot is turned away from the center, the imaginary center line of the body. The medical term for that is called abduction, A-B-D-U-C-T-I-O-N. Unfortunately, it's opposite, adduction. They sound very, very similar. And if you have someone who speaks quickly like me or doesn't have good enunciation, sometimes people confuse those two terms. Now, when we go beyond the foot and ankle, when someone pronates and has excessive pronation, as seen here, what ends up happening is that starts to affect the patient further up what's called the kinetic chain of the leg. So when you have overpronation, what actually ends up happening is the lower leg actually rotates too far in. It actually, so basically to try and give you a visual of this, which is kind of very difficult, when someone overpronates, I'm going to take this off. So when they overpronate, their tibia, their lower leg, actually rotates in. The next step up is the knee. What ends up happening? Their Q angle of their knee becomes greater. That's known as genuvalgum, or the old-fashioned term that people used to use called knock knee. Well, when you have an increased Q angle of the knee, what does that do to the Y angle of the hip? Increases that. What do we have running down here? Our IT band. How many people have IT band problems and they're just told, oh, you have a naturally tight IT band? Well, why do you think their IT band's tight? If it has to get pulled again and again and it's trying to fire to antagonize that, of course the muscle's going to get bulky, but it's also going to get very tight. So it's just not stretching of the IT band. You got to look at what's happening at the foot, because if a person has a pronated foot type, they can do all the stretches they want, but as soon as they get up and walk, that pronation is going to overwork the IT band again. Going up further into the pelvic girdle, obviously if you have a combination of all these factors, that creates instability at the sacroiliac joint, where the pelvic girdle meets the lower spine. When that happens, you actually get increased rotational forces on the lumbar spine. What do we have between the individual vertebral bones? That nice disc. It is not, I can tell you that most people who get into their middle life and older, who do that one motion, all of a sudden they blew out that disc. It wasn't that one motion that blew out that disc. Dime to a dollar, they probably had biomechanical abnormalities in the lower extremities starting at the feet, that every step they took their entire life, there was increased rotational forces, and it gradually weakens and weakens and weakens and weakens the outer rings of the disc until that one day where the patient bends down incorrectly and that weak area of the disc goes on them. Unless it is severe trauma, high, fall from a height, high impact motor accident, and that just completely blows it out. Usually someone has had this in the making. You had a question?
As a cyclist, I'm a cyclist as well.
Right.
Did you ever see that in cyclists being in, even if they're fit properly for the bike?
Absolutely, because when you're on the bicycle, and this is a great point, obviously proper bicycling form and when we're fit properly, and just even when we go into spinning class, obviously people are supposed to be adjusted. Technically, your perfect cadence and your perfect foot position is always supposed to be parallel to the ground in your cadence. Well, when you're walking, when your foot's in contact with the ground, if you drew a line across the bottom of the foot and a line of the ground, that's parallel too. So although you are not putting full weight on your foot on the pedal when you cycle versus when you walk, those biomechanical abnormalities are necessary. And as I get into biomechanical treatment, and I get talking a little bit about the orthotics that we make in our practice, I'm going to show you some of the orthotics that we make that are versatile enough to go from shoe to shoe to shoe, including a cycling shoe. I wear my orthotics inside my cycling shoe, and if I didn't, I can tell you right now, my knees would be killing me and probably my lower back too. Because again, especially on your power stroke, you come down and push, if your foot inside your shoe pronates, it's still going to create a valgus knee position, increase Y angle, increase SI joint stability. And what happens is, and watch footage of cyclists. The thing about cyclists is most of them have already been biomechanically analyzed and they have orthotics. But you can tell the ones who are kind of new to the team or new to the sport, you can see it looks like they're dancing on when they're sitting down because biomechanically there's something being transferred. Yes, exactly. That's a very good point to bring up. At the opposite end of the spectrum, over-supination. Basically what I call too much of a good thing. The foot's so rigidly developed, you actually have too high of an arch. Essentially, and you've seen these people, it looks like when they're standing or they're walking, they always look like they're on the outside edges of their feet, that you're like, how's this person not spraining their ankle every step they take? Or if you see someone standing in their bare feet, it looks like you pull a Volkswagen Beetle up and park it underneath their arch. And they look like they could be very good at riding a horse, because when you're supinated, you usually have genu varum, or a little bit of bow-leggedness. So it's the exact opposite. So there you have a picture of supination. Excessive longitudinal large height, inversion of the heel, and adduction. Basically, some of these people, in addition to having a cavus foot type, also have a little bit of a condition called metatarsus adductus, which means the front half of the foot is turned in a little bit too much. So they're a little bit pigeon-toed. I saw you mouthing that. So that's kind of the old-fashioned term for it. So over-supination creates the exact opposite situation all the way up the kinetic chain. Now these people, what's interesting is, because they're so rigid like that, they're the ones that can develop stress fractures of the fifth metatarsal bone in the foot. They're also the ones that can develop a lot of stress fractures in the fibula. We always talk about stress fractures of the shin bone, the tibia. That usually happens in people who are uncompensated, who are overpronated. The ones who are oversupinated and uncompensated, they're the ones that actually get the lesser common but just as bad stress fracture of the fibula. Actually, a member of our filming team here, David, is the exact opposite of me. He has a cavus foot type, and he was dealing with many biomechanical problems. And I did a gait scan on him, and I said, I don't even know how you've gotten as far as you have with your activity. He's very much into aerobic activity. He's a cyclist. He's a runner, trying to talk me into do some triathlons himself. So again, he was having all types of problems, even up into your knees, weren't you?
Yeah, I had knee issues, my left knee. And I was cycling regularly, never wore any orthotics. He fit me with orthotics. Then I had an idea. I wanted to try him in my cycling shoes, and I put him in the cycling shoes, and it was night and day. I mean, it was instantaneous pleasure. And then one day I had the pain come back again, and I said, "There's a problem." And he looked in my shoes. He pulled out something simple. It's so stupid. He pulled out my orthotics, and I had the left on the right and the right on the left. And it looks like when you put them in there, it looks like the left should be the left and the right, but it doesn't. You can't fit them that way. So
yeah. Imagine having two different prescriptions of contact lenses and putting them in the wrong side. You'd be like, wait a second, something's wrong. Another question.
So what are your thoughts on barefoot running?
We're gonna get into that. We're gonna get into that. And you know what, David, you get a chance out in the waiting room there. There's a red bag and then there's a pair of open shoes right there. Can you go in the red bag and pull the shoes out and bring both pairs in for me? Thank you. So obviously, what the sequelae of having improper biomechanics? Well, no kidding. There's going to be overload of anatomic structures. You're going to have pain. I will tell you that my patients who have ankle injuries, even just sprains, once they're healed, I'm kind of getting them ready to kind of spread their wings and fly. I'll do a biomechanical analysis and take a look and make sure that biomechanically they're stable and they don't have to use an orthotic or an ankle brace, either long-term or for specific high-impact or high-demand activities. Question, the proper angle. What do you think happens to the balance or mechanical advantage balance of all the different muscles and tendons that attach to the toes? They're not in balance. So if they're not in balance and one group of muscles is pulling more than another, what's going to happen to those toes? Deformities. Bunions and hammer toes don't primarily come from wearing improper shoes, my friends. It comes from abnormal biomechanics. Every patient that comes to my office, that they're on my schedule, new patient, is interested in possible bunion or hammer toe surgery, not only do they get an x-ray, they get a gait scan. And you know what? I've seen 0 people in my career in 15 years who have a neutral foot and have deformities. Every one of those patients who have digital deformities have biomechanical abnormalities. Again, because think about it, all the tendons that attach to those toes, all those muscles' origin points started on the other side of the arch. Whether it be the intrinsic muscles of the foot, which start and end in the foot, or the extrinsic muscles, all the muscles that start up in the calves and work their way via tendons down into the foot and to the toes. So every one of my patients, if they are at a severe enough point and symptomatic enough that we're going to engage in surgery, I tell them surgery is 50% of my job. After your surgery, you're going to wear these orthotics. Why? Surgery fixes the deformity. It doesn't fix the biomechanics of their foot. So if I do surgery on them, get those toes nice and straight, get that bunion gone, and they move on with life and don't wear orthotics to balance out the biomechanics that caused the problem in the first place, what's going to happen? Recurrence. Recurrence of the deformity. And I see it. I've been in practice long enough that patients have come to me and said, I don't understand. 20 years ago, Dr. So-and-so did surgery on my bunions or my hammer toes and my feet look great. I was so happy. And now over time, I swear to God, it looks like the deformities are coming back. We do x-rays. We do a computerized gait analysis. After they're done, I walk back into the room. First question I ask, did the doctor take time to talk about a cause and effect? Most of them actually say yes, he did. And yes, I did have orthotics, but I was so excited about how good my feet looked, I really didn't understand that whole relationship. And over time, I got lazier and lazier, didn't really wear them as much as I should. And to be honest with you now, I kind of probably threw them out or don't even know where they are. And I tell the patient, well, you know what? If you don't want the recurrence, the mild recurrence you're starting to see, get any worse, time to get you back into orthotics. So I see a lot of that. And you got to think about that. You got to think about that. Yes, wearing improper shoes or poorly fitting shoes can aggravate the problem, but it's not the cause of the problem. The painful conditions. And again, on the CD-ROM I'm going to give to all of you, which have PDF versions of the educational materials that get handed out to my patients in the office, they're all on here. But again, we talked about it. The biomechanics start at the foot, work their way up the shins, into the knees, into the hips, and into the lower back. So obviously, and I'm going to get a little bit more into some of the more common ones as we move on, but I would have to say numero uno as far as painful condition in my office, as far as active people, plantar fasciitis, which is also incorrectly called heel spurs, and I'll get into that in a little bit. Neuromas. Because of the abnormal uneven distribution of weight on the ball of the foot, as a patient leaves mid-stance, if the foot's not neutral, then what ends up happening is the weight transfer into the ball of the foot is not evenly distributed. You overload small nerve endings that pass between the metatarsals, branch and go into the toes. You compress on that nerve, it develops an inflammatory condition, and then that nerve cannot conduct its electrical impulses correctly. You can get pain, you can get numbness, you can get burning into the toes. And I know one of the questions that were forwarded to me by the trainers were people who are having problems when they're on the cardiovascular equipment, that their toes and ball of feet are falling asleep. I'll get into that in a little bit. Tendonitis. Again, if the foot's not posturally stable, these muscles are working 3 to 4 times harder every step a person takes to try and stabilize it. So the muscle exerts its force through the tendon. If the tendon gets overworked, it develops inflammation, you end up with tendonitis, or even worse, if the problem worsens or goes on and is not put into check, internally inside the tendon, you develop inflammatory nodular conditions called tendinosis. Shin splints. That's a little bit related, especially to the tendon called the posterior tibial tendon. Basically, especially if you're overpronated, the posterior tibial tendon, which attaches on the medial and backside of the shin bone, the tibia, which then becomes a tendon, runs down around the inside of the ankle and attaches in the arch. So when you overpronate, not only can you pull on the tendon and develop tendonitis, but Sharpie's fibers, which are where the muscle fibers attach into the periosteum on the shin bone, they start to get pulled and you get inflammation in there. Obviously, if you let that go unchecked, what is that going to lead to? It's going to go from tibial shin splints to overload of the tibia enough that you end up getting stress fractures of the tibia. Also, stress fractures of the metatarsals, somewhat related to neuromas. Again, if a person isn't biomechanically stable, not only are they overloading that nerve ending, they're overloading the skinny little what we call the lesser metatarsals, metatarsals 2 through 5. Again, those little tiny thin bones aren't made to take up the weight the way that the first metatarsal is, which is what leads up to our big toe. So again, you end up with that. I talked about the Q angle at the knee. Obviously, if the Q angle is incorrect, then guess what? Your patella is tracking abnormally over the femur. So you can have a patient do VMO strengthening exercises all they want until they've got a bulging VMO, but if they stand up and they pronate, that muscle doesn't have the proper mechanical angle of pull. They can have a huge VMO, it's still going to, because of that Q angle, the patella is still going to drift abnormally over that knee joint, and they're going to still have pain. And the pain is called chondromalacia patella, which means that the cartilage on the underside of the knee bone is getting scraped. Pes anserine bursitis, a bursa of the knee, again, very common in overpronated people. IT band syndrome, we talked about that earlier. I talked about the abnormal Q angle of the hip. That rubs the high IT band and you end up getting a hip bursitis. We talked about the SI joint instability. A lot of people with the biomechanical problems where you have the increased Q angle, the piriformis muscle gets overloaded, and you've probably heard of the term piriformis syndrome, and of course the lower back pain. So again, a lot of things can arise if the feet aren't working properly. Nice little picture here depicting someone with a pronated foot, genu valgum. Supinated foot, genu varum. Neutral foot, when the foot is stably aligned underneath the lower leg, that gives you stable alignment of the knees. One thing I always like to talk to patients is that medicine is science. This is not theory. And again, science is definitely a field that if you don't have accurate, precise, and globally reproducible results from tests, then you don't have answers to anything. And I always say this because a lot of people are lulled to sleep by advertising. What I mean by lulled to sleep is there's key terms and keywords that people use. Clinically proven. You know what? I can open up a broom closet down the street and call it a clinic and take 10 people and run a study and then try and market a product. Or we can take thousands of people in a randomized double-blind placebo-controlled study with statistically significant numbers of subjects and give you real answers. And again, that's with the computerized gait analysis, this is what it was based off of. It's based off of the biomechanical principles, but finally being able to find a way to actually measure it. And essentially the gait analysis is made up of 2 things. It's made up of a pressure plate. This plate has 900 sensors per square centimeter. And along with the plate, and I will do a demonstration at the end of the presentation, there is visualization software that takes the information from the plate and creates a visual analysis of the patient's foot. So this isn't only used, a lot of people think, oh, well, you use that to make orthotics. Yes, ultimately, if we determine that a patient needs orthotic treatment, we will make orthotics. But for me, it's a visualization tool, because what we have the ability to do is not only analyze that patient's gait, but then to take that patient's gait and compare it to an optimal neutral foot. And right there, right on the screen, the patient doesn't have to be a doctor to say, wow, there's my foot in the left, there's what my foot should be doing on the right. Wow, now I really understand what you were getting at about my foot's not functioning correctly. And again, the big thing is quantifying this. Just like when we have our eyes examined. I'm nearsighted. My daughter's nearsighted. However, my prescription's negative 4.00. My daughter's negative 0.75. Big difference. If I put her glasses on, they wouldn't do anything for me. If she put my glasses on, she'd be stumbling over her feet, because again, so that's the big thing is, it's like vision. Not everyone's nearsighted has to wear a pair of Coke bottle glasses like Joe Paterno did. And the same thing goes with biomechanical intervention for the feet. Not everyone requires just the same. It's not a 10-minute car wash type of thing. You got to analyze these people and look at it. Again, there's the entire setup with the software. And again, that answers the guesswork, because we could have 10 podiatrists lined up and watch them have a patient walk. Just watch them walk. And the thing is, the 10 of us may all have some similarities in what we see visually, but we all may also have some little individual subjective differences of some of the more subtle things. The gait analysis takes all of that out of the equation. So obviously, what does this come to for me? Well, normally, patients who show up to my office obviously have severe enough biomechanical problems that they need more than just a good shoe. They need more than a good shoe and an over-the-counter retail-grade orthotic. They need a prescription orthotic, and it's made for that person only. And again, the big thing we're looking to do is bring the foot into neutral at mid-stance portion of that stance phase of the gait cycle, as I mentioned. Also equalizing ground reactive forces, not only as they hit the foot, as they travel up through the shin and the knee. Obviously providing the proper axis alignment, particularly of what's called the subtalar joint, which is the joint the subtalar joint is right above the heel bone, but below the ankle joint itself. The subtalar joint is the key stable joint for the entire lower extremity. So a lot of people who talk about ankle instability, a lot of it's actually coming from their subtalar joint. And I had another question that was forwarded to me by Renee from the trainers. Orthotics. What situations do they help? What situations do they harm? Orthotics should not be harming anyone. If someone has analyzed a person and determined you should be in some type of orthotic, orthotics are passive support. They should be designed to help support the person's foot, not force the person's foot or body into doing anything. So there really isn't any harm intended with orthotics. And I'll get into that a little bit later here about that whole concept. In some people who have very, very severe biomechanical abnormalities that we can't use an in-shoe orthotic, we'll utilize something called a Ritchie brace. And this is, again, something custom. And it contains not only the prescription orthotic, but also prescription upright. Some people are just so bad that their arch and foot is collapsed so bad that it's actually abnormally affecting the ankle. And again, these things, it's a hinge. It's not a solid AFO. And I see a lot of people walking around with these things, and I can't believe that their clinician has them in a solid AFO anymore. Those things are miserable to use. And a lot of people who need a solid AFO, it's because they only have weakness of the front muscles, not the back muscles. Well, guess what? You put them in a solid molded AFO, they can't use the muscles that they already have that are working normally. This allows a patient, especially in someone with a foot drop after a stroke, we can actually build these with a spring-loaded hinge that they can still use all the muscles that are strong in their leg that weren't affected by the stroke, but instead of having to lift their leg up like this, because they're weak in those front muscles, as soon as they pick that foot up, the spring-loaded device in that brace brings their foot up. So no more of the steppage gait that looks like they're walking like a horse to clear their foot off the ground. Again, when a patient comes into me and we identify, hey, you have this intrinsic biomechanical factor and we want to get you into orthotics. In the meantime, while we're in the process of making the orthotics, obviously we go back to the extrinsic factors. And again, especially if I'm getting referrals from personal trainers or physical therapists, people like that, a lot of these people have already addressed these things. And again, I mentioned if the foot biomechanically isn't in the right position, a lot of the postural muscles, including the gastrosoleal muscles, the IT band muscles, the hamstring muscles, the external rotators of the hip, are working 3 to 4 times harder. So again, we do provide a little bit of education to our patients about this, but again, many of these patients have already done that as a kind of a first line of defense. Proper shoe gear and especially shoe gear lifespan. You know, if someone wears a shoe at least 3 times a week, within 4 to 6 months, no matter how good that shoe looks, it's worn out. Runners, I tell them keep logs. Keep logs of your training. 300 to 400 miles, then it's time to get them out of the running lineup and using for a casual beat-around shoe. Proper training techniques, again, with the group that I'm speaking to now, I don't have to worry about that. My job's already done there. I don't have to get into it. With people who aren't utilizing trainers, I do try and point them in your direction just to let you know. And if they're still a little bit kind of iffy about that, I'll at least give them a little bit about, the biggest guidance that I give them, especially for the cardiovascular training, is to spend the $60, $70 and get yourself a heart rate monitor. Because you know what? I learned it myself. I was going on perceived effort. First couple times I went out with the heart rate monitor on, I'm like, well, no wonder I feel like I'm dead. I feel like I got a good workout, but I feel like I'm dead the rest of the day. I was in my catabolic anaerobic zone the whole time I was training. Now I can go out for a 3-hour ride, and I actually have a bike computer with the heart rate monitor built in with actual alarms that go off to let me know when I'm outside of my training zones. I can go out for a 3-mile ride and come home on the weekend, still have enough energy to spend time with my family, get stuff done around the house, and I don't feel like I want to lay around the rest of the day. So I do, if they're totally just out there and they're not really into wanting to get with a personal trainer, you know, that I'll at least give them that bare bones type of guidance. And then of course, obviously, whatever inflammatory side effects of the soft tissues or joint structures, obviously I'm going to point them in the direction, whether it be an oral anti-inflammatory. Some people have such trigger point tenderness, I will give an anti-inflammatory injection. Sometimes I will send them to a physical therapist to get things like the modalities such as ultrasound e-stim treatments. I can't believe how many people who think that if you go to a physical therapist, all they're going to do is work you over, exercise you, or stretch you. I can't believe how many people don't realize that they can get ultrasound treatments, e-stim treatments in the physical therapy session, along with some manual hands-on work. Again, surgical considerations I mentioned, and for me, my criteria for surgery is when a patient tells me that I have so much pain that I can't palliate this anymore. I've tried to buy bigger shoes. I've tried to put pads over the knuckles of my hammer toes. It doesn't work. I do not do surgery for aesthetic reasons. There has to be pain and limitations in functions, and obviously my x-ray images to show that there is a severe enough deformity. But again, the two things that go together are the surgical management as well as the biomechanical control. My surgeries are done outpatient. They're done with IV sedation, and I do something really neat called regional anesthesia. Essentially, the anesthesiologists are able to localize nerve endings in the lower leg and give specific nerve blocks to those legs, to those nerves, and then they place a small pain pump catheter. For 3 to 5 days after the surgery, the patient has a little fanny pack filled with 700 cc's of the numbing medicine that's delivered through a continuous running pump. What that means for the patient is their pain is controlled. They don't have to pop pills. If they don't have to pop pills, I don't have to worry about them being all loopy and stumbling around and possibly falling and hurting the site that I just worked on, or God forbid, hurting another area. I don't protect my surgical patients with the little flimsy post-op shoe. That is proven biomechanically to take no pressure off of the surgical foot, and in some case studies that have been done with them, with the little post-op shoes, it actually increases the pressure on the surgical area. I use the moon boot, the cam walker boot, thing that goes up to about here, has all the straps, has a little curve on the bottom. That cam stands for curvature activated motion. What that means is as a patient walks, although their ankle is locked and they can't bend their foot up and down, that curve makes the biomechanics of that leg act as though that ankle can actually move. It makes a patient be able to walk relatively normal, but the curve also reduces 30 to 40% of the midfoot and forefoot pressures off of the foot. So my patients, and I get this all the time, patient comes in to see me for a surgical consultation and admits to me, you know, I've been getting the nerve up to see you for weeks, months, whatever, because they hear all these horror stories. And the first thing I ask, these horror stories, were they any of my patients? No. Second thing I usually ask, did you talk to them at length about what happened postoperatively? Usually the answer is yes. And I'll go and I'll get out a little flimsy post-op shoe. I'm like, let me ask you, did the person you talked to tell you they wore one of these immediately after surgery? Oh yeah. I pull out the walker boot and tell them what I just told you, and people breathe a sigh of relief that they were so worried about how much pain they're going to have. I also talk to them about this regional anesthesia. My patients come back post-op and are like, doctor, I know you did, just as a safety measure and a backup measure, provide me with a prescription for pain pills, but I haven't taken any because that pain pump has kept me under control. You got to utilize modern techniques to help treat patients. Scar tissue within joints and tendons. I'm very big into minimal incision surgery, and one of the big things I do is arthroscopy and tendoscopy, which utilizes small incisions, microcameras, and micro instruments to clean out chronic inflammatory or scar tissue. There's me looking inside of someone's joint. Someone had fallen, broken their ankle, and developed a little bit of post-traumatic bone spurring. So every time their foot bent upward as they went to walk, they were feeling pinching in the front of their ankle. Got in there, cleaned out that bone spur. Patient came back 5 days later, was already asking to get out of the cam walker boot. She's like, I haven't felt this good in 20 years. She had broken her ankle 20 years ago, and she got the typical orthopedic answer, what do you expect? You broke it. You're just going to have to deal with this pain until it's bad enough, and then I'm going to fuse your ankle. That was the option she was given. Never was given the option for arthroscopy. Another person, and this happens commonly, that for you, as you twist your ankle, if you could break that down into milliseconds as the ankle is twisting, the top of the internal ankle bone, the talus, bangs up against the bottom of the shin bone, the tibia, and sometimes what happens, it's enough of force that it actually breaks free some of the cartilage. So we're actually able to go in there now, clean out the non-viable cartilage, and I'm going to go over a technique a modern technique I use in a couple of minutes called platelet-rich plasma, where what I can do is actually clean out the bad cartilage, clean out the bad bone, and actually inject something called platelet-rich plasma to actually help that area heal better. And sometimes arthroscopy has to be used diagnostically, meaning when I've done x-rays, when I've done ultrasounds, when I've sent a patient for MRI and I'm not finding anything, but their subjective complaints are just telling me maybe the diagnostic studies aren't telling me the entire truth. You can do diagnostic arthroscopy where you just go in, you're not expecting to see any, you don't have any proof on your films that there's a problem. Here was a patient that she had an MRI, a high field MRI, meaning the most powerful MRI you can have as far as studies go. It was read as normal. I looked at her studies myself. I looked at her films. I'm like, you know what? I can't find anything, but the symptoms you're giving me are very similar to what's called an osteochondral lesion, meaning an area of damage to the cartilage and underlying bone. Sure enough, I got in there, and something looked weird about this, so I took a little tool called a blunt probe, and sure enough, when I pushed on that area that looked unnatural to me, all of a sudden that flap of cartilage lifted up. I cleaned out the cartilage, cleaned out the bone, did the platelet-rich plasma injection, and to this day, she's asymptomatic. So it's amazing how, and again, these are incisions that are this big. 2 stitches to close, stitches stay in for 10 days, the patient's out of the boot within 10 to 14 days. Sometimes if they're really at me saying, I feel great, I will get them out sooner. And here's actually me looking inside of someone's tendon. They make small enough scopes that instead of filleting someone open with a 6-inch incision and opening up their tendon and cleaning out scar tissue or fixing a tear, which then leaves them with a huge scar, and obviously scar tissue is not very pliable, and when you're talking about a tendon, it needs to slide and move and be pliable. That's not what you want to look at. This was actually looking inside of, all of that is chronic inflammatory tissue that was unresponsive to conservative methods. Here's what a normal tendon should look like. There's the sheath, the covering of the tendon, and there's the tendon itself. And here, another patient that just was giving me all those signs and symptoms of a partial tear, MRI negative. I got a scope in there. Look at that split running down her tendon. That's a little blunt probe. And again, and what was great about this case was, and you don't see it on this particular picture, and again, it looks huge here, but remember, that's blown up on a high definition screen. I'm talking about a scope that's 1.9 millimeters in diameter. So the lucky thing was, this was a small enough tear, I was able to excise that little piece of tendon, and again, I did a platelet-rich plasma injection, and she didn't have to go on to any further surgical intervention. Question?
So your platelets, so that's pretty much skin that's actually growing around the tendon, right?
No, it's not. It's not. I'm going to explain it. I'm going to explain that in a couple of what platelet-rich plasma is. One of the other things that I do for microdebridement of painful fascial tendons is what's called topaz radiofrequency. The traditional way, again, of usually doing procedures to address painful fascial tendons was open incisional procedures. When I have someone who has just a chronic inflammatory condition, the tendinosis, or they've had plantar fasciitis so long that there's so much scar tissue in their plantar fascia called plantar fasciosis, I actually do a treatment percutaneously. Essentially, the topaz radiofrequency wand gives off small little bursts of radiofrequency sound wave treatment, and what it does is basically shrinks up and ablates the chronic inflammatory tissue. Where this technology came from was the ENT surgeons who have to do tonsillectomies on adults. We don't like tonsillectomies in adults utilizing typical cold steel, meaning taking a scalpel and cutting someone's tonsils out. In adults, it's a lot riskier because the tonsillar tissue is lymphatic tissue. That's when you get sore throats and things like that, your tonsil tissue works to fight that off. But if you have someone who's been affected again and again, those tonsils are actually unhealthy. Well, when you physically cut tonsils out of an adult, there's a lot of chance for infection, bleeding problems. They actually do this type of procedure where they put a little radiofrequency wand into the tonsil, they keep firing off the burst of radiofrequency, and they see the tonsil just shrink up before their eyes down to a little nub of tissue. So no bleeding, no risk of postoperative infection. We actually took that technology to use it because our goals were to make less incisions, have less potential scar tissue, quicker recovery, and less complications. So with this procedure, what we do is when I have someone who has, say painful plantar fasciitis, I actually will find the actual area where they're most painful. We numb it up with local anesthesia. You don't even need to do IV sedation with these procedures. We put small little pinpoint holes in the skin, put this fiber wire through the skin, and we can actually feel the fascia. The fascia is a very broad band of tissue, and we do basically 0.4 second bursts of this radiofrequency sound wave. I can literally actually feel through the treatment wand, I can feel that fascia, that tight, chronic, scarred up fascia actually releasing literally through the wand. And again, this thing takes 15 minutes to do. They are in a walker boot for 3 days. Because if I got that fascia, all the chronic bound up inflexible fascia taken care of, I don't want them locked down in a boot. I get them walking right away with this, doing some light stretching. And to be honest with you, I had most of my patients who exercise, I usually let them get back to getting on an exercise bike within 7 days after this procedure. And usually getting back onto an elliptical machine 3 weeks after the procedure. As far as running, about 5 to 6 weeks. So if I were to have actually made an incision and opened them up, they wouldn't be back on a low impact machine for 8 weeks. So I look to cut these people's downtime down to literally nothing. Platelet-rich plasma injections. First off, just to let you know, I've been doing these for almost a dozen years, but of course now all of a sudden the biggest catchphrase in the sports media is platelet-rich plasma injections. And I don't know why some of these athletes are going to Europe for it. It's FDA approved in this country. I don't know why they're flying over there. I don't know if enough of doctors don't believe in it or don't have enough experience with it, but I've been doing these for almost a dozen years. So what we actually do is we draw off 10 cc's of the patient's blood. So that's considered autologous because it's coming from the patient himself. We remove that, it's placed into a special high-speed centrifuge, and what that results in, so when we spin this down, we spin that 10 cc's down, it packs all the red blood cells at the bottom of the tube. What is left at the top is what's called platelet-rich plasma. So basically what platelet-rich plasma has is it has all of the healing factors that are involved that make you heal an area concentrated. Now here we go. Now there'll be a test that, no, I'm just kidding. But essentially what you're looking to do is the platelets actually encourage our adult stem cells that are also included in these platelets. When a stem cell touches another body cells, there's called chemotaxis, meaning that immature cell recognizes the mature cell it's touching and then differentiates into that mature cell. So if I take platelet-rich plasma, inject it into someone's cartilage area where the cartilage was scraped off, those stem cells are touching that surrounding healthy cartilage. They mature and differentiate into healthy cartilage. If I've got someone with a bad tendon and I have to clean out some bad tendon, I inject that platelet-rich plasma into there. The stem cells in that platelet-rich plasma start to mature into healthy tendon cells. And then all of these chemicals allow ingrowth of healthy blood vessels and also make sure that the blood vessels have permeability. What I mean by that is the blood vessels have to be able to diffuse oxygen from the blood cells that are flowing through it. And that's the big difference about platelet-rich plasma, is some of the older techniques of trying to grow healthy tissue. And again, first we tried to grow healthy tissue in lab conditions, and then trying to transfer it into the body didn't work very well. We realized we had to take the patient's own body tissue and do it. So again, it's not, what you're getting at actually is, this is, yeah, biotissue, and we actually use this when we do skin grafts and things like this. We'll actually do the platelet-rich plasma. We get the graft in place. Underneath the graft, we'll inject some of the platelet-rich plasma too to actually help the dermal and epidermal cells mature. So there actually is a place for that. It's more kind of the dermatologic plastic surgery type of realm, where I'm talking more musculoskeletal. You know, the clinical questions I took from the trainers. As far as the heel fracture patient, it was someone who apparently had a fracture, was seeing a doctor, they were following the patient, doing follow-up x-rays, had determined, hey, you healed the fracture enough that we're going to let you get back into activity. Now, I guess the patient got back into the gym and apparently went away on a trip or something like that and did a lot of walking and aggravated it. Well, again, you know, you got to realize that when you return to activity, obviously there's going to be a little bit of reconditioning of the body. So that can aggravate it. If there's still healing process going on in the heel bone, that could be something that's being aggravated. And again, the big thing that I would really have to see to be able to evaluate that fully, did the heel fracture itself extend into that joint called the subtalar joint? When you have fractures that extend into joints, they usually on average will adversely affect that joint. And that's what I was getting at in that earlier slide when I talked about biomechanical effects at the feet. Trauma, especially in the feet, can affect biomechanics. I will tell you that my patients who have ankle injuries, even just sprains, once they're healed, I'm kind of getting them ready to kind of spread their wings and fly. I'll do a biomechanical analysis and take a look and make sure that biomechanically they're stable and they don't have to use an orthotic or an ankle brace, either long-term or for specific high-impact or high-demand activities. Question?
Just going back just a couple seconds. Did like Costador, like he got
Yes.
up on blood doping? Would that?
No, it's not. It's not.
Yeah.
First, the World Anti-Doping Agency said it considered it doping, and then they had to have scientists.
It's not 0.000001%.
Right. Well, for the blood for in relation to platelet-rich plasma being blood doping, it is not. It's not. Why? Because you're not injecting any red blood cells. And literally, what happened was when this started becoming more popular, without thinking, the World Anti-Doping Agency said it's doping. Literally, we had to have doctors go in front of this panel and show them step by step the science. And of course, then the WADA had their own scientists that said that they had to turn to the members of WADA and say, yeah, these scientists are right. It isn't blood doping. It is not. If you look on the United States Anti-Doping Agency, it was about 2-3 years ago, and the release is still on there that they considered it not doping. It's not doping. Heel spurs. Again, all of us, both at the area where the plantar fascia attached at the heel, as well as where the Achilles tendon attached at the back of the heel. We have a natural enlargement of bone there to allow those structures to attach. When you look at an x-ray, obviously you're looking at a three-dimensional body part on a two-dimensional screen or piece of paper. Those little enlargements of bone look kind of sharp and abrupt like a spur. So that's where this whole misnomer of heel spur comes from. If people get pain in the bottom of the heel, it's not from the spur, it's from the plantar fascia. If people get pain at the back of the heel, it's not from the spur, it's from Achilles tendonitis right where the tendon attaches to the heel bone. So I like to put that to rest. Again, we talked a little bit about the neuroma, the ball, the foot pain, numbness, toe numbness. Again, people come into me with neuroma-like pain. I put them on the gait scan and we see that the biomechanics are such that they're not evenly distributing the weight across there. But again, so someone gets on the treadmill or gets on the elliptical, even when they have proper form and they're keeping their foot flat on the pedal of the elliptical and not having the habit, which I have myself of, I notice I really get into a workout, I kind of start leaning and I start raising on the ball of my foot. If a person's spending the time and effort to keep their foot flat on the pedal and they're still noticing the toes are falling asleep, the biomechanics should be looked at. Plus there's one other thing. Even if they're doing a good job of keeping the foot flat, make sure they're also not leaning forward and their center of gravity looking like it's getting more towards the ball of the foot. So, I'm not sure what trainer had submitted that question, but that's if you have any of your patients start to talk about that, definitely, that may be something that needs to be evaluated medically. Again, orthotics doing harm. When we look at someone, and I have some people that come into my office that are having some low-grade things, and I take a look at them, and I find that their biomechanics aren't very far off from being completely neutral. Sometimes I'll tell them, you know what, you're not in orthotic territory now. I give them a little bit of direction about different styles of shoes, sometimes suggest maybe an over-the-counter orthotic, but most of the time when orthotics are doing harm, it's because someone's tried to use an over-the-counter orthotic when they should be in a prescription orthotic. Again, over-the-counter orthotics are prefabricated. They're not made for that patient alone. They're not made to address specific problems. That's why people say, oh, I tried an over-the-counter orthotic. I felt like it didn't match the shape of my foot or my arch, and it actually hurt me. That's where an orthotic can do harm. But as far as prescription orthotics doing harm, it's kind of almost an oxymoron. Then there was someone who mentioned they had a patient who had an ankle fracture, and they were told by the orthopedic surgeon that they had weakness and pain from the plate and the screws. Well, weakness, the plate and screws are there to hold the fracture in place and allow it to heal. Now, if they're having pain, if they're trying to put on a boot or other high-riding shoe, again, once all your swelling goes down, there's not a lot of skin coverage, a lot of soft tissue coverage over the fibula bone. That's where usually we have to put the plate and screws. If the x-rays show that thing's healed, and they're having problems from shoe gear rubbing the plate and screws, that's a walk in the park surgery to take those screws and that plate out. The tiny little holes in the bone that are made by the screws themselves, within 2 weeks you can't even see those holes anymore. So that, compared to when they had the original injury and had to have the surgery to fix the fracture and everything they went through there, that's nothing to have that taken out. Now, if they have weakness, again, they ought to have biomechanically be analyzed to see if they need something like to be using a lace-up ankle brace when they exercise or wearing orthotics. And there was also a mention in that Renee forwarded to me that the patient was also having pain in their ankle joint. Well, they may have residual scar tissue from the fracture itself and they may need to have an ankle scope. I tell every one of my severe ankle sprain patients and my ankle fracture patients, you got this problem I got to fix and work on now, but just to let you know, you may develop post-traumatic scar tissue in that joint, and I give them an education sheet about the scope procedure itself. So they were kind of the things that Renee had forwarded to me, and again, all these conditions are on these PDFs. I'm going to hand out all these discs to you. I also have information brochures about the gait analysis itself. As far as my willingness to listen to stuff, things like that, please take down my phone number and my email. You know what? I love, eventually I can see myself as my career moves on teaching. I really can. I think education is so important. I think in medicine, 90% of patient care is educating the patient and making them logically understand what's going on, why it happened, because I find that when you explain to a patient not only what do you have, but why you have it, I feel that the patient leaving my office has a solid basis of knowledge of, hey, I understand logically why these are the treatment plans laid out for me, and I'm going to follow through with these. I have very high patient compliance, and again, my goal for patients is to keep them active and keep them healthy, and I know the last thing you all want is to see your patients breaking down and then losing their motivation, saying, you know what, I'm going to drop, I'm not going to do training with you, or you know what, I need to take some time off of the gym, and then you never see them again. I know that's highly demotivating for you as trainers. It's highly depressing for me when I see patients. They say I can't exercise or do what I want to do or how I want to do it. That ends my presentation. Real quick, I'm just going to open up the gait scan software just to give you an idea of what we look at on the gait scan itself.
Can you address the barefoot thing while you're getting that over?
Yes, please.
Yeah.
So, the only people who should even consider barefoot running technology, whether it be the Vibram 5 Fingers or all these, and I bought a pair myself, and I'm going to speak about my own anecdotal experience, or the minimalist shoes such as the Newtons, and obviously all the companies are now trying to catch up with Newton. So, if the vast majority of people don't have perfect biomechanics and have a neutral foot, they shouldn't be in those shoes. The only people who can get away with those shoes are those genetically few gifted individuals who have a perfectly neutral foot. And even that being said, they may want to watch how many miles within one session they're putting on there, because even a neutral foot needs a little bit, some help. Where this whole technology came about is that obviously when you're talking about shoes, trying to address biomechanical abnormalities, whether overpronated foot, oversupinated foot, the shoe is still trying to do it from an extrinsic factor, meaning that the way that the sole's built, they put different densities of material. But guess what? If you had multiple miniature cameras inside the shoe, guess what? That patient's abnormal motion still would be taking place inside the shoe. Perfect anecdotal experience. I had a patient who came to see me a few weeks ago, was a runner, and wanted a gait analysis. That's what he called for. He said, I want to see Dr. Felton. I know he works with runners. I want a gait analysis. So I walked in and started getting history. And he actually had a cavus foot type, oversupinated. And he said, look, I wore this shoe, that shoe, this shoe. And finally, I went to a running shoe store. And they put me into more of a neutral shoe with a high-grade over-the-counter orthotic. And he said, immediately, my problems felt a lot better, and I realized my whole life I was trying to treat my foot on the outside of the shoe rather than doing something on the inside of the shoe, and that whole experience with that running shoe store of going to a neutral shoe but with something inside to address my abnormality was the key. But now I want to go to the next step and get an insert made for me and me only. So that's my answer to that. And so again, I decided to, I preach this all the time that I don't believe in the barefoot running technology or the minimalist shoes. So I went out and got myself a pair of minimalist shoes. Now, even with my orthotics in here, I bought these and I broke them in, and I tried to spend a whole day on a Saturday, a day that I had a busy day running around, going from here to there on my feet. 3 hours in, I started developing literally posterior tibial tendonitis pain, which is what I had in my adolescent years before I realized I needed orthotics. And so again, even a minimalist shoe, what happens is basically the upper, it just doesn't, I mean, look, this has my orthotic in. And look how I can still bend the shoe. That's literally torquing my orthotic up inside of there. And that's just with my hands. When you walk, you put 2 times your body weight through your foot every step. So if my little flimsy arms can do this, imagine what 190 times 2 is what? 360? 380. So imagine what imagine what was happening with 380. Basically, you can even see just by the little bit I've been walking, you can see I pronate, whereas in my more of a traditional shoe, I can bend it where it's supposed to bend, right at my toe joints, but I can't make that thing bend right there. So this is a perfect complement. This is actually a neutral style. It's a neutral style traditional running shoe. But all these pundits that are saying, oh my God, you're wearing these big heavy shoes and building them up, they're right. You don't need something built up on the outside, but they're wrong on what they're trying to say is that you need almost nothing at all. And I can't tell you how many people I've seen who've on their own volition going out and bought the Newtons and things like that and are in my office. And 9 times out of 10, well, when did your problems start? Within usually a couple of weeks of starting to run with those Newtons. I had one patient, and God love her. I love working with runners, but some of them just kind of want to go out on a limb and a branch and be different. I had a patient who been treating for first treated her 3 years ago with orthotics. Within 3 weeks after she got her orthotics, her symptoms were completely gone. All of a sudden, she popped up on my schedule a couple of months ago. having a problem with orthotics. Walk in the room, she's got the Newtons on. Well, what's going on? Well, the pain's back and the problems with the orthotics. Okay, well, how long ago did this start? About 2 weeks ago, but you know what? I really was excited to come in and show you these shoes too. Newtons. Well, how long did you get the Newtons? Three weeks ago. So you're telling me 3 weeks ago you got Newtons, which was the change in your life, and you're telling me the orthotics that you've been wearing 3 years with traditional shoes, they're the problem? Where within a week after you started wearing the Newtons, your pain come in? And it fell on deaf ears. The other day I saw her running. She lives close to me. I'm driving up Seminary, and I know right where she lives. She was only maybe 45 seconds to a minute to run. I saw her stop at the side of the road and start shaking her foot. I'm like, you know what? I can lead you to water, but if you're not going to drink, you know. Seriously, I mean, this is science. If I looked at you with a computerized gait analysis and said, hey, here's the problem, and we made an orthotic off of that, you put it into your traditional running shoe 3 years ago, and you've been doing great up until a couple months ago, and the one change in your life was the Newtons, what does that tell you? That your foot's not built for the Newton. Like I showed you, even putting my prescription orthotic in a minimalist shoe, something kind of akin to a Newton, doesn't work. Doesn't work for me. So let me bring a gait scan up here. There's the patient's gait scan on the left. Here's an example of a neutral foot. So again, you don't have to be a doctor to be able to take a look at that and say, wow, my foot's really not functioning too well. Yeah, patient with actually, oh yeah, she had plantar fasciitis, shin splint pain when she ran. She's definitely, you take a look at this in a neutral foot, the progression of the center of gravity, the way it should be, look at how she's all over the place. All over the place. Yeah. And she got her orthotics before, she got her orthotics right before Christmas. And I saw her for her three-week follow-up. She was liking the orthotics, getting into a groove with them, and I think she's coming in to see me next month for her long-term follow-up. But yeah, I mean, so there, like I said, again, this opens people's eyes very, very quick to exactly what their feet are doing versus what their feet should be doing. So, all that being said, I'm going to pass out to you all.
So I had orthotics made years and years ago.
You have them made from a plaster of Paris mold of the foot?
No, I stood in like a tray that had cushy stuff. So they make them from
the gait scan.
the gait scan.
I actually have examples of orthotics up here. Basically, the way the orthotics are made now is with CAD/CAM technology. So those scans that you just saw that show a patient what their foot is doing versus what their foot should be doing, we actually take those scans and they're sent off electronically to the lab with the style of orthotic I'm looking to make for a patient. And what happens is the shell of the orthotic, which is the piece that's designed to support your foot, which goes from the heel to just behind the ball of the foot, which the shell of the orthotic is kind of akin to the lenses of your glasses, is actually computer carved off of your scans. It starts out as a big, thick piece of material, but because we have so much precise and accurate information, what ends up happening, I'm going to get you guys these in a second, what ends up happening is the shell of the orthotic, and again, every orthotic, and I'll talk a little bit about that too, the shell of every orthotic goes from the heel to just behind the ball of your foot. The shell of the orthotic is about 2 millimeters thick. And all of the control is actually built into this shell. So you don't necessarily have to have that big, thick, clunky thing on the heel or anything like that, or the big, thick, clunky thing underneath the ball of the foot that tries to balance you out. It's all built into there. Now, obviously, depending on the physical size of a patient. If I've got a truck driver who drives truck all day, jumping in and out of his truck, weighs 270 pounds, and he comes home and takes off his work boots and puts on just another pair of boots, and he's a big, burly guy, needs to really have a lot of support. Yeah, on him, I may build what's called the extrinsic post on there and things like that. Also, top cover. The top cover plays no role in the support of the foot. So another misnomer or improper terminology people use is full-length orthotic, three-quarter-length orthotic. What the two words are missing in there is top cover. And again, the top cover plays no role whatsoever. What I like to do with my orthotics is I make a sulcus length top cover. Essentially what that means is, again, the shell goes from the heel to just the ball of my foot. The top cover extends to that little point where your toes kind of start and end on the bottom of the foot. So it sits in there nicely, doesn't take up a lot of room at the front of your shoe. And what that allows a lot of people to be able to actually do with the orthotic is most people who are wearing orthotics, obviously the majority of their life they've gone through getting used to the feel of this up against the bottom of the foot. When you make a nice small thin orthotic, what you end up doing is you take up so little room inside of the shoe, you can put the orthotic inside the shoe and leave this in there. And this thing does not provide any support. This is a sock liner. This is not an insert, it's a sock liner. And this thing, when the body weight comes down, it completely crushes it down almost flat, adds a little bit of cushioning, and that's about it. So when you put your orthotic underneath there, it does not take away from what the orthotic is doing. And that's kind of the way I've always worn my orthotics in my running shoes. But the great thing about making a nice, small, slim, low-profile orthotic like this is you take this out of your workout shoes and you put it in your other shoes too. It's like glasses. When it's determined that we need eyeglasses, most of us, our eye doctors want us to wear those corrective lenses from the time we wake up to the time we go to bed. Same thing with your orthotics. Every step you take, not just your exercise. Not just your exercise. So
what's the lifespan of it?
8 to 10 years. That's the other thing about when you carve this out, the shell out of a solid piece, versus the way yours were made, which for quick educational purposes, the way yours were made, that impression that was taken of your feet is called a negative impression of the foot. It was sent to the lab, dental plaster or Paris was poured in it, made a positive mold. Then they took a piece of this material, real thin, heated it up and bent it around the shape of your foot. When you take a polymer of this material, and this is material engineering and chemical characteristics, you bend the molecular arms of those polymers. You instantaneously weaken the material and decrease its lifespan by 50%. That's why old thermal molded orthotics actually lost the shape of their curvature within 3 to 5 years after wearing them. And the way that the labs tried to make up for that, they tried to use a thicker piece of material. What does a thicker piece of material do? Take up more room inside of your shoe. Yeah, so 8 to 10 years for these are called CAD/CAM, computer-aided design, computer-aided manufacturing type of orthotic. It's top-of-the-line technology for orthotics. Unfortunately, and I don't know whether it's cost prohibitions because of the cost of this equipment or if it's practitioners' reluctance to embrace technology, but I can tell you in the greater Baltimore area, we're the only practice that uses the orthotic group gate scan. We're the only ones. There's some other scanners out there. Their plates aren't as sensitive. Like I said, ours has 900 sensors per square centimeter, and the other technologies and companies that are out there that have this, their software isn't as accurate as well. So, and again, when you're talking about medical care, you want accuracy and precision, especially with biomechanics. Any other questions? All right, I think I put you guys to sleep enough for one afternoon. Thank you. Thank you.
Thank you.
Absolutely. And again, the other thing that I had mentioned to Renee too, that from time to time, and maybe not every month, maybe every other month or every quarter, if you guys are coming across in your working with your clients and you have little case situations or things like that, if we get like 5 or 6 trainers that each of you have a client or something that has something going on, and you guys want to do like a little round table kind of a case presentation, present to me, and I can give you, just based on what you're telling me, kind of maybe some ideas of what's going on with this patient, that as well. But again, feel free to call me, text me, email me. Like I said, that last digit of my phone number is 7, not a 4. Don't want you calling Joe's Pizza Place asking for Dr. Felton. What? Oh, I'm sure you have. Oh, you do? Oh, God, I race with Team BBC. Oh, you have one? Someone back there's missing one. Yeah.
Are you going by the Q sheet? I mean, sticking on the Q sheet with the staying in the small gear, small ring.
Yeah. Yep.
See, it's hard for me.
Well, I was a pusher for years, man. I was a gear.
So.
Yeah. See, you have to push. Yeah, you got him out. I was a pusher for years, and then I realized, you know what? It's not.
It's efficient training. I know. And I do like one day a week. I'll stick to.
Yeah.